Hello, everybody. Welcome to Town Hall. Great to have you with us today. I'm looking out at a sort of gray day, which is the first day of move-in. So I went out for a little while. This is a remarkably well-behaved move-in. I'm used to a Big Ten campus where basically they just open the doors and thousands of people come in and try to move into the dorms all at once. And here, like people have, set times or 20 people are going to show up during this time, and it's all very orderly and much less chaos than maybe would you'd expect. So I don't know. Alice and I are going to show up to see if we can't help some people move in tomorrow and get wet probably at the time. Not that we need more rain. So Sally, how did with the big storms earlier in the week, how did your area fare?
We fared well. We did not have any power outages. We did not have any flooding. There were periods of heavy rain, but the streets never flooded, so I didn't have to close my pipe in the basement to stop the water from backing up into our basement.
Mhm.
So we were fortunate. I know many others were not.
So Melissa, how about you?
It was like nothing happened out this way. No debris.
So where is out this way? Iowa?
Fox Lake.
Okay. All right. All right. Well, obviously it was dramatic here. So,
Yes.
Mhm.
um,
Crazy.
yeah, I'm going to take this as a plateau and sort of get us started.
Mhm.
So, today we're going to talk about healthcare benefits here at RFU. I'm going to do a little bit of update and then I'll introduce our panel. So I think the largest news for our folks here on campus for the week has really been the storm. And the power outage that happened on Monday night. So, and then through all of Tuesday. And on Monday, if you weren't actually here, the storm was big enough that it like opened doors to the great outside. The front door, the door in my courtyard, they actually got sucked open. And water came in. There was water coming into the library. I saw water coming in down by where our engineers are. So a lot of people doing a lot of work to clean that up and then keep everything going. So we lost a generator in all of that, and so we'll have to find the 100K to replace that generator. And but the other generators held, the vivarium held. People brought dry ice in for the cafe to keep the food in order. Student, our student wellness folks found ways to try to help people if they had refrigerated medications and things like that. So I just really appreciate all the people who did so much work. We had faculty who moved exams because we obviously couldn't do exams on Tuesday when we didn't have lights. So many people making adjustments and making everything work for people. I really, really do appreciate that. Move-in starts today. I think there's over 240 or 250 folks. I've lost track of the number moving in, and then orientation, more than 400 folks starting next week. So I guess summer is over. Fall has started, and as students come back to campus, it'll be great to have them with us. The EVPR search has moved on to the next phase. I'm in negotiations, and so we'll see how that all turns out. But I appreciate all the work of Corn Ferry and our search committee and everybody who met with the candidates throughout the whole thing. And then because there's no rest for the weary, we are starting the provost search. So I charged the search committee this morning. My thanks to Dean Wu for heading that up, for chairing that committee, and Lee Concha and for staffing it for me with across the board, and then Jonna Purcell for providing support to the committee as well. So I'm looking forward to that. The provost search or the provost position is probably to a president. That's the person that we would lean on the most, because the mission of the place depends on what faculty and students do, and that lives in the academic world of the provost. No town hall next week. I'll be at white coat ceremonies on Friday, so there'll be no town hall next week. We'll reconnect after that. So that's my sort of update. I'm more than happy to answer questions about anything that you might have. Feel free to put those into the Q&A in case there's something that you wanted to hear about and I didn't mention it. But so on to the business of today, we're going to be working on talking about health benefits here at RFU. For that conversation, we have Sally Madden, who is our Associate Vice President for Human Resources, and Melissa Haley, who's our Manager for Payroll and Benefits. Just as a sort of an outline of what we're going to be working on, we're going to talk about what we have to get done as an institution. So we've been presented with a 28% increase in our costs from the insurance company. That's about $3.7 million. And if you'll recall, the gap that we were trying to close from FY26 to 27 for our budget to get to a break-even budget and not eat into our endowment was $1 million. So obviously, this is a significant piece for us to deal with. Now, we've known about it for a little, for a few months. And so that budget, we've been thinking about this and working on it. And I guess at some level, like we're working on our plans across the board. One of which is, our endowment is doing well, like most of the 401ks floating around, but our endowment is a little small. So we get about 5% of our operating budget off of the endowment from the proceeds from the endowment, and our peers would get about 12%. So that means that we have to find funding elsewhere, or we have to be careful with our expenses beyond that. So my goal is for us to meet budget because I don't want us to eat into our enrollment or not enroll into our endowment, because that is not only how we get operating expenses, but it's our path to growth. And I think overall for the institution, we need to find ways to grow. And I don't want to lay people off. So laying people off is not only demoralizing and painful, but it's actually bad for people. So the
Agreed.
the data is, if you compare the public health impacts of inflation to layoffs, layoffs are much worse for people's health. So overall, I'm trying to avoid layoffs. So just so you know where I'm headed, I will do what I can to decrease costs and things like that rather than lay people off. I had a good conversation with a Senate counsel about this maybe 3 weeks ago, something like that, when it sort of we've heard about it. They had some really interesting ideas about maybe how the university could support options for people. And I think, in our conversation today, some of that will come up. How might the university, even if it can't do everything, how it can help people do some things that they value. And I want to keep the more or less 80-20 split, where the university pays about 80% of the insurance cost and our people pay about 20%. So those are sort of my introductory comments. I don't know if Sally, if there's more that you would have me introduce, but you have a PowerPoint that we're going to go through
Yep.
and then we're going to answer questions. So let me turn
Yeah.
the screen over to you a little bit.
The only thing I will say is that we were very surprised at the renewal rate when it came in. So we have been working closely with our broker and Blue Cross to do what we can to negotiate those initial increases without changing anything. And we have been able to make some progress, but some of the things we're talking about today are other options that are under consideration. So we do welcome your input, your questions. We may not be able to get into the nitty-gritty on this particular call, but as you know, Melissa and I are always available, as is the rest of the HR team. So we encourage you to reach out to us, meet with us, correspond with us, whatever, so that we can answer your questions.
I suppose that is important. Like we have not made decisions. We're going to talk about the timeline of decision making in one of these
Mhm.
slides, but we're still working and
Absolutely.
listening. The whole point of this is to get some thoughts from folks.
Great. I'm going to go ahead and share my screen then. All right. So again, thank you very much, everybody, for joining us today. Like we said, we're going to go through some particulars about our healthcare plans and things, like Erin said, that are on the table right now for us to consider. And again, we welcome your feedback and input. I think Erin's going to manage the question box for me, so we will do our best to answer all and any questions. First of all, like we said, today is an update. We want to provide some basic information about how our medical plans work to make sure that there is a shared understanding. Number two is where the renewal stands, just update you on some of the costs and the actual rates that were presented to us, explain what is driving the costs, and then listen. We want to listen to you, answer any questions and concerns, and make sure that we understand your priorities as we look at this challenge. Just for background information, you all should be aware that we offer 4 insurance plans. 2 of our plans are HMO plans, which are fully insured. What we want to make sure is that people understand what that means. So, in a fully insured plan, the insurance company takes on the risk. We are provided with the premium costs, we pay those premium costs, and the insurance company manages all of those claims. The PPO is the other type of plan that we have, and that is self-funded. And what that means is that the risk is on Rosalind Franklin, and we pay the covered claims up to a stop loss limit. So if you go to your doctors and you incur $100,000 in medical expenses for a surgery, RFU is paying that claim cost completely. We pay that full 100%. The insurance company kicks in after we hit that stop loss limit of $145,000. So just want you to be aware of that. That is the way the plan has been structured from the very beginning, at least for the 10 years that I've been here. It's a very common practice for higher ed institutions. And, that's the way that the plan works. And for your own information as well, we have about equal numbers in each type of plan. We have approximately 300 employees in the HMO plans and about 330 people in the PPO plans that we offer.
And the reason they're traditionally self-funded is that it's essentially like having a deductible, right? The overall cost is lower when we
Right.
self-fund to some degree, and of course we're not administrating it. You're not, I when I go to my doctor and I'm on the PPO plan, I don't ask RFU to cut a check, right? Blue Cross Blue Shield manages that, and then RFU pays
Yes,
back behind the scenes.
absolutely. So we pay those invoices that are actually come in bi-weekly, and we pay those invoices through the finance team. So this is, it just shows that where we're at currently. So our current annual cost for our medical, including the pharmacy, is about $13.2 million. We already talked about the 28% increase that we received from Blue Cross Blue Shield, which is an additional 3.7 million. And then overall, that would be a renewal projection of $16.9 million, which is obviously a very big number. And that's before any of our proposed changes. So 3 forces are driving the increase, higher prescription drug costs. If you haven't been seeing that in the news or in newsletters that you're reading, that is something that everybody is experiencing. All of these changes are not just to RFU. It's impacting all organizations, universities. It's just the price of healthcare these days. So we've got higher prescription costs. We've got more complex and persistent claims. People are getting sick. There's chronic conditions out there. There's cancer. There's all kinds of just terrible illnesses out there, and we are not immune to those. And then we've got higher stop loss insurance costs. So, like we said, there is a stop loss level. And because we have high claimants in the plan, that has driven up our cost for our stop loss insurance as well. The good
Yeah.
news is, oh, sorry, go
No, go
ahead.
ahead. Go ahead.
I was going to say employees are using in-network doctors, but it is still at a very high cost. So the challenge is, like the slide said, primarily the rising cost and complexity of the healthcare, not a lack of responsible plan use.
Yeah, I mean, as an example, right, if you're people who go on immunotherapy for cancer, which they're life-saving drugs, the program cell death drugs are life-saving, but they are not treat and be done, right? Those are drugs that people continue on,
Mhm.
as is the case for the biologics for rheumatoid arthritis and any of those others. These are persistent, which is one of the things in, that second box, right? Is that these are treatments. This is different than the way things used to be for, especially for cancer. Um, and our population is older than some other businesses and corporations.
Correct. So we are evaluating a targeted package to reduce the increase. So one of our proposals is that what we want to do is consolidate the two HMOs into the Blue Advantage HMO. We've done an analysis on this and very few members are impacted. I believe we've got 18 individuals. Basically, those two HMOs provide the same exact benefits. The only difference is one medical group is not part of the HMO Illinois network. Sorry, did I say the reverse of that, Melissa? So
Yeah.
one of the groups from HMO Illinois is not in the Blue Advantage HMO. Melissa is going to keep me on
Correct.
track here. She knows the intimate details of these plans better than I do. So, Melissa, feel free to speak up. But
Yeah.
again,
So I mean, just to throw it out there, it's group number 489. The Northwestern Medicine Physician Network is not in the Blue Advantage HMO, where it is in the HMO Illinois.
thanks
So
for that clarification. So the good news is if you feel strongly about that particular practice and physician in the practice, you can still have that physician, but you would need to move to the PPO plan. So obviously consolidating the HMO into one plan saves money on administration. We would only be administering one plan, not two. The HMO Blue Advantage also has a broader geographic and provider access. 5 years ago, HMO Illinois' network was bigger. That's not true today. The BA HMO now has a larger network. So that is really something that we are hoping to do. There's also something that has been mandated by Blue Cross, and that is prescription formulary refinement. So we are going to be moving to biosimilar drugs as part of the move going forward. Basically, they still solve the same issues. They're just less expensive medications, and they are similar. Like they're called biosimilar for a reason, and they cost less than some of those other biologic drugs. Weight management GLP-1 coverage, we're considering stopping and eliminating that coverage specifically for weight loss. It will still cover diabetes, other chronic medical conditions. Those will remain, but we are looking at removing those weight management GLP-1s, which is a trend we're seeing across all industries and particularly in higher education. And then we are looking at selected PPO plan design changes, adjusting some deductibles and out-of-pocket maximums, and then also increasing the cost of those prescription co-payments. Anybody want to add anything? Melissa, Aaron, we're good? Okay. All right. So what we're hoping to do also is control some of these costs with employee support. So RX and Go would be a new offering. It is basically a mail order drug program that the employees would pay zero on those medications. So how that would work is you would need to get your first fill through your pharmacy. So whatever the 90-day pharmacy is that you go through now, that first fill would need to be filled through the insurance. After that first fill, you transfer that prescription to RX and Go, and then the cost to you would be zero, and the university will be billed for the actual cost of the medication. This should be able to save the university about 30 to 40% in those prescription drug medications. So we are asking you to help us with this, and your help, would also keep those costs down for what the plan is paying on those prescriptions. It covers things like all kinds of chronic condition medications. And we're looking also, because we would be eliminating GLP-1s for weight loss, we would be looking at a direct purchase access option through RX and Go, where again, it would be a discounted rate for those medications. The second thing we're looking at is HSA contributions. If you are in the high deductible health plan with the HSA, currently right now the university is not making contributions to that plan. So in order to entice you to move into the HSA plan, the university is looking at making a contribution to that. It will help you pay for that deductible. So it would be $500 for individual coverage and $1,000 for family coverage. And it would help in meeting that deductible cost prior to the medication or insurance kicking in. So it is available through the high deductible PPO HSA option, and that would be the only plan that would be available for. Finally, we're looking at providing weight management assistance. So as we talked about in reducing or eliminating the GLP-1s, we are looking to reimburse up to $1,000 annually for anyone who is on these GLP-1 medications. So it would be potentially available to all eligible covered participants. We would have to create what is called an HRA, which is a health reimbursement account, to be able to do this legally and provide some support for those medications. So we are currently in the process of talking to a vendor about the design and implementation of that option. We just need to get information as to how that would work so that we can consider this as an option. Additionally, we introduced Twin Health last year at open enrollment time. It is a wellness benefit that provides support for people who have diabetes or who need weight management support. The BMI levels last year were you had to be at 40 to be able to participate in this program, and they have reduced that number down to 30 now. So if you have a 30 BMI, you are now eligible to participate in this Twin Health program.
So, one of the conversations that happened at the Senate Council was, as I was talking about the GLP-1s, like they're like, well, what could you guys do? And so, I mean, RX and Go would decrease the cost to some degree, which would be significant, but not entirely. And then if the $1,000 would help decrease the cost additionally. And then conceivably, if you had family coverage in the PPO, there could be another $1,000 RFU contribution through the HSA. Do I have that all correct, Sally?
Yes, you do. And I think for the HRA that we're talking about, you wouldn't have to go through RX and Go. So I know there's other providers of these medications like Him and Hers and Roe, and there's so many different vendors out there now. I mean, that $1,000 could go further if you do your research and come up with the best plan for you that's the least expensive. So we would be able to reimburse through this HRA, and it wouldn't have to be through that RX and Go program. It could be any vendor that you would get those medications through. Okay. So if we were able to execute on all of those recommendations and ideas that we just went through, we would be able to reduce the increase from 28% to about 21%. So the chart kind of explains the math there. So it would be still about 16 million that the emerging package would be. And the estimated net increase would be 2.8 million over what we're currently paying now. So the employee contributions, like Aaron said, we are really diligently trying to keep those cost contributions at that 80/20 level. But the premiums are going up pretty significantly. So the expected increase could be anywhere from 7 to 20%, and that's going to be dependent on the plan that you're in. Do you have family coverage? Are you just doing single coverage? It will vary depending on what you are seeking. And we obviously will not be passing on the full increase to the employees. We are again striving to keep that 80/20 split. So today we are looking for questions and comments, concerns. Anonymous feedback is welcome. We're here to answer any questions you might have. We are interested in your feedback. We will continue to, work with our broker and Blue Cross Blue Shield to try and get solutions finalized for how we can bring this rate increase down. The next milestone is going to be finalizing these renewal decisions. We will communicate those plan changes just like we do during open enrollment. And actually, we have open enrollment targeted for mid to late August. And we need to make some decisions, and we will get that information back out to you. But we do appreciate that these benefits are very important to everyone. Like, this is the top benefit that we can provide to people. And so it is really a challenging year, and we're going to do our best to keep the plan as strong as we can. That is all I had.
Well, great. So we have a whole group of questions. So we're, I think we'll start on that. Do you want to?
Can I stop sharing?
Yeah, you can. And maybe we'll need it again if there's some data that we need to show. But so
Okay.
the first one from Anonymous is cutting budgets leads to employee loss as well. How does the university plan to track and minimize the effects of these less obvious staff loss outcomes? And I'm not quite sure whether that's, more work per person that they mean or other losses. For example, the retirement benefit, the match dropped a few years ago. So which I keep in my head, right, as one of the things
Mhm.
that staff and faculty lost a few years ago. And so, and also, I mean, we track what's happening with turnover and a whole range of things like that. So, and when I was thinking of cuts, I mean, I was thinking mostly of, first we try to increase revenue, right? And then we try to manage our costs, and managing our costs is one of the ways we can avoid layoffs. But there's no doubt when we don't hire somebody and don't get to do something, or don't hire somebody and the remaining people have to work harder, there's no doubt people feel that. And then Anonymous asks, is today's recorded presentation available for a family member to watch? And the answer is yeah. Usually these are up by Monday, Friday or Monday. It sort of depends on how the world is working. Robin Dreyer asks, thank you for all you've done. I'm very grateful there will still be a PPO option. Otherwise, your strategies seem very sound. Thank you, Robin.
Thank you,
Anonymous
Robin.
Anonymous asks, what are the drawbacks of biosimilars with regard to GLP-1s? Aren't weight loss issues a major contributor to poor health, which would just keep us incurring additional insurance claims due to those poor health issues like heart disease, blood pressure, diabetes, for keeping pre-diabetes from turning into diabetes? And so biosimilars are thought to be mostly the same. It's not exactly like a true generic, it's just in the same family. So the most common problems are that they are different. So sometimes people will react to one drug in a way that they didn't react to the other one. So there are a few, but by and large, the biosimilars are supposed to be going after the same targets. Um, so, but I will admit that that's one of the relatively new areas in therapy in these biologics. With regard to GLP-1s, so the idea is, are GLP-1s the cost saving in the long run or health saving? And the answer to that is they are definitely health saving. There's not much evidence that they're cost saving. So, but that's certainly a wonderful thing for people not to get diabetes or heart disease. That's why we're trying to do what we can to maintain them. It's just a cost that's very difficult for us to manage. Um, yeah. So, yeah. And I'm happy to take another swing at that if people want to ask a question in a different way.
I mean, I would
Melissa?
just, yeah, I'd just jump in and say
Yeah.
that, as a reminder, it's just the weight loss that's not going to be covered for the GLP-1. So if someone is diabetic, those drugs will still be available to them.
Yep. Anonymous asks, is RX and Go only for PPO? Does it cover HMO as well?
It is only for PPO because prescription coverage is part of the HMO contract that we have with Blue Cross Blue Shield. So it would only be for that PPO plan.
Is there a way the university can work with the pharmaceutical companies that offer discounts for GLP-1s? So there are programs from individual companies that if your insurance doesn't cover it, they have a reduced cost, which tells you something about how the economics of this are working and and what they really should cost, maybe. So, but we probably are not going to have the size and scale to be able to specifically run with one of those companies, nor would you necessarily want us to pick a company. So, but these are additive, right? So if there's $1,000 and you have a deal with the manufacturer or the pharmaceutical company, that $1,000 comes off that cost. To have that all right, Sally and Melissa?
Yep. Yep. And like I said, there's new companies offering these GLP-1s for weight loss every day. And so, that $1,000 can go further if you find a good deal out there that's not maybe RX and Go or one of the other companies that are out there. So do your due diligence would be my advice there.
Yeah, and I looked it up. The GLP-1s, the first ones go generic in 2030. Um, Although then there will be orals, which of course will have their own patents that go longer. So for whatever that's worth. For HSA contribution, if you have no children, do my spouse and I fall under family coverage? And before we answer that, I just want to say there's a limit to the amount of detail we can provide on individual versions in the town hall, and some of that will have to go to open enrollment. But Sally, what are the general rules on that?
Yes.
Or Melissa?
So if employee and spouse, they do fall under that family contribution.
Anonymous. How much would the deductible be for a high deductible PPO insurance with the HSA contribution versus what is it currently? And that may be one of the places that, well, I'm out of my depth.
Melissa, do you want to crack at that one?
Sure. So currently the high deductible health plan deductible is $3,400 for the individual and then $6,800 for the family. We may see that increase by a couple $100 for the renewal. But as of today, it's $3,400 for the individual, $6,800 for the family.
David Miller asks, would you consider creating a progressive fee system for health insurance? For instance, the University of Chicago has a 5-tier system. Less than 50,000, 50 to 75,000, 75 to 100,000, 100 to 175,000, and greater than 175,000 for those in higher tiers paying more for the same health insurance coverage. Additionally, copays appear to be at odds with the basic purpose of insurance, which is to help protect people from the cost of medical care, and they hurt those in the lower tier more than those in the upper tier. What objectives do copays serve? Well, so there are about 3 questions in there. I'm going to start at the end. Copays are there for a variety of reasons. One of the reasons is to give people, to encourage people to be good consumers. Whether or not that works is an empirical question that I don't know the answer to. And I suppose it depends on your philosophy of insurance, right? So personally, I tend to think of insurance as to help me avoid financial catastrophe. So, you know, I may or may not, I tend to have, I try to, the cheapest way to have insurance is to not use it, right? And so the less you use it, the less your insurance would cost on general, right? So that's why there are high deductible plans to try to keep the overall cost of insurance down and for people who choose to have insurance to avoid financial contingency. The reason for Medicare and the reason that people like me might support a universal version is to try to make sure that everybody gets care when they need it, which is a separate social question. So, yeah, I think everybody has their own philosophy around how they're thinking about the insurance. I am intrigued by the tiered insurance plan. There's no way we're getting that done by next week, but I'm more than happy to think about what it would look like in coming years because there's no doubt that a flat cost is regressive, particularly for people who have lower incomes. So that's intriguing, David.
Yeah, and it's not common practice, but it doesn't mean that we shouldn't look at it as an option.
Yeah. Anonymous asks, why do we not have HSA available in the non-high deductible plans? My previous employer allowed HSA contributions to the PPO plans. This would help decrease some of the costs. I don't know the answer to that.
Yeah, I don't
So
understand.
the
Go ahead.
deductible has to be a certain amount. And off the top of my head, I can't remember what that amount is, for the plan to qualify as a high deductible health plan. So if that threshold is not met, then the HSA would not be able to be part of it.
Anonymous, obesity is recognized as a complex chronic disease, not simply a matter of willpower. True. Um, and I think that's part of the reason that we're trying to figure out a way to um, put money behind that. Anonymous, out-of-state employees only have the option for the PPO plan, which is significantly more expensive. Is there a thought on finding other cheaper options for out-of-state employees? In addition, has the university considered offering an even higher high deductible plan where the university redirects its premium contributions into an employee's HSA to pay the full deductible instead of the high monthly premiums? I don't know the answer to that, but I do know that high deductible plans tend to be cheaper. And I don't know what it would mean for us to redirect the reduced premium back toward the full deductible. I'm going to have to turn to Sally and Melissa to whether or not such programs exist or how they work.
Yeah, I don't think we've considered that in the past. We have such a low number of participants in the HSA right now. I think people are still confused about how they work and what the benefits are. Um, we have approximately, I think, 48 people currently in the HSA plan. So there hasn't been a ton of interest in it. But, again, I think we can certainly look into other options if we felt that that would move people into those plans. But I think we've got to educate first and make sure that people understand what those benefits are.
And then
Melissa?
Anonymous had asked a first question. Out-of-state employees only have the option for the PPO. Is there are there other ways, or have we looked at um, other programs for out-of-state employees? And I'll say this is bedeviling for lots of institutions when you have people working at distance, and the cheapest plans are HMOs, which are based on a group, which are almost always relatively local.
Yeah. Melissa, I don't know if you have an answer for that one. I mean, we've only recently started hiring a number of people from out of state. So I think it's it's something that we definitely should start looking at because I think that number has been growing. Um, I don't know, Melissa, if you heard from those remote employees at all, I guess, I don't know.
The PPO plan covers across the country where those HMOs are such limited networks. And to have a large participation in one state to be able to offer a
Yeah.
network it's, I don't know that it would be financially feasible. Obviously, administrative costs would be a concern, having so many different plans available. Um, but that is the reason why the PPO plan is mostly taken by those out-of-state participants is because it reaches across the country.
Anonymous asks, apologies if I missed this, but I didn't see the HMO consolidation and the potential cost savings. How much does that save in costs, especially since it directly impacts several people in HMO Illinois? It wasn't in the waterfall. I don't know what
Yeah.
the actual number is.
I probably have that somewhere, but not at the tips of my finger.
Yeah.
I
Um,
think our renewal was initially expected to be I think around 20, was it 21%? And then it was an additional 7% savings to consolidate the plans. But again, I don't have that
Right.
right in front of me.
Bill Frost asks, can we anticipate another 28% increase each year mandated by Blue Cross? Are we completely at their mercy? And I mean, we are looking at what I think Bill is suggesting, which is, are there other options out there for the institution? And we don't have the opportunity to get that done this year, but it is one of the things that we're thinking about. Because they are overall probably a pretty high cost option. I think that one of the things that we're thinking about as we make these changes is that uh, costs are going to continue to go up. And so we are trying to figure out how to manage those costs. Because if we don't manage at least a part of them this year, we're going to manage them again next year. It's just going to get bigger.
Mhm. And I
Uh,
think just Aaron, just if I can add a few years back, we actually talked about looking at other options to Blue Cross, and the overwhelming response from most of our staff was they'd rather pay a little bit more and stay with Blue Cross. I mean, Blue Cross is based here in Illinois. It has the market for the most part. But I think as these costs continue to rise, we are going to have to look at other potential providers.
I know that some of our clinical the hospitals and folks like that have added other insurance companies, in part to to have a little competition. People may or may not choose them, but it, um, it does keep us out of the not having any choices at all. We'll
Mhm.
just have to see what the next year brings for that. Anonymous says, please consider changing the HSA vendor. Inspira is just awful. If there's another cost-effective vendor, please switch to them. Uh, we will try to, we will think about that. How's that? That's um, Gary asks, is there any expected change in access to doctors' networks in the PPO? And the answer to that is no, right?
No.
Right.
Anonymous asks, if the RX and Go is only for the PPO, will there be any discount option available for GLP-1s in the HMO plans?
So the RX and Go will actually, for the cash option on the GLP weight loss medications through RX and Go will actually be available to our entire community, not just those enrolled into one of our medical plans. So if you are in the HMO plan and you choose to do the weight loss option, cash payment through RX and Go, that will still be available to you.
As would the $1,000 contribution from RFU.
Correct.
Pharmacy by mail, Anonymous asks, pharmacy by mail companies are notorious for selling customers' data. RX and Go says they only use anonymized data, but how will our highly sensitive information be protected? I'd, to the extent that HIPAA protects us from anything, which it doesn't, it would be protected. But I think Anonymous's concern is probably, well, I'll be honest. I was talking to somebody who works for the military, and it turned out that they had access to what was giving people and not.
Mm.
So yeah, fascinating, huh? So your neighborhood pharmacy may well be no better or no worse than what's happening with the mail order companies. HIPAA just means that they have to tell you that they're selling your data, not that they can't sell your data. Anonymous says, will GLP-1s still be included in the new plan for pre-diabetes or only with the diabetes diagnosis? If pre-diabetes is still covered and the diagnosis of pre-diabetes has pre-existed, well, okay, wait a second, let me do that again. Will GLP-1 still be included in the new plan for pre-diabetes or only with the diabetes diagnosis? If pre-diabetes is covered and the diagnosis of pre-diabetes has existed, well controlled with the GLP-1, would that individual still be covered? And I don't know the answer to that. I'm not sure any of us know the answer to that.
Yeah, I guess my thought is because it is still going to be covered for diabetes, if there is that pre-diabetes designation, then I think it would be covered, but we'd have to check on that.
I
I
think
mean,
that really it depends on the coding from the insurance company,
yeah,
right?
exactly.
So Blue Cross and Blue Shield is managing that, and it all depends on the coding. Anonymous says, we switched to the HMO several years ago when the PPO increased dramatically. We've been happy with the HMO since almost all of our doctors were already in the plan, but we haven't had a serious illness. Have RFU employees complained about the HMO for serious illnesses?
No, it's still meeting the needs of our population. Yeah, Melissa, you're more directly related or involved in that, but I have not heard any complaints about the HMO
Yeah.
coverages.
I think the only concern I get is when, for example, if a preemie is born, I've had somebody mention that they'd like the child to go to a certain specialist and, they couldn't get a referral because that specialist was outside of their medical group. As long as you're okay with all the physicians and specialists that are within part of your primary care physician's medical group, then I don't hear any concerns, other than, what I mentioned.
Anonymous says, thank you for all you do in trying to keep the costs manageable and keeping the PPO. I personally do not mind paying a bit more on my premium in order to stay on the PPO and continued coverage of my very important medications. Fair enough.
Yeah. Mhm.
Anonymous, will there be any incentives offered to opt out of of RFU insurance? That was an interesting conversation, right? And
Mhm.
there's already a set of rules around whether or not around how spouses are covered or not covered by their insurance. That was one of the things we talked about, but it's not one of the things on today's list. Pamela Chambers, changing the FSA to an HSA with the option for investment and not losing our money at the end of the year, at the end of the plan year, might encourage more use. Why do we not have that option?
Those are two totally separate things. The FSA is completely different. Melissa, do you want to elaborate?
Yeah, the FSA is completely different. So those that are not eligible for the health savings account by participating in a high deductible health plan, that's an alternate option to them. But if you are in a high deductible health plan and you are able to contribute to an HSA, you cannot participate in the medical flexible spending, but you would be able to participate in the limited purpose flexible spending for dental and vision only. So a lot of that comes down to the IRS rules of how those plans can be administered and what's offered with them.
Anonymous asks, this might be a modest effect, but I'm using Good RX for a medication I take daily. The cost is about the same as the deductible. Many may not know about this.
Yeah.
And
Thank you.
I think the
Yeah.
pharmacies do, when somebody goes in to have their prescriptions filled, I know there's a lot of pharmacists that do recommend that you check with GoodRx. And of course, there's all the advertising that's out there on the TV and radios and such to help educate people about the GoodRx. But it's not something that we promote internally with RFU.
Anonymous says the current policy should be updated to lower the high deductible health plan deductible to 1,700 and the maximum out of pocket cost to 3,400. In addition, the employer should contribute 700 annually to each employee's health savings account. Uh, I would love to make everything cheaper and put more money like there is a I don't know if there's something specific to the 1,700 and 3,400.
Is that the minimum, Melissa? I'm not sure.
I was just going to say that may be the minimum for the high deductible health plan to be able to participate in the HSA.
Okay. Um, Anonymous Sally, I think you said this but didn't catch it. Does this go into effect with the next enrollment? Yes.
October 1, yes. I mean, again, no decisions have been made, but the any plan changes that we're talking about right now would be effective October 1.
Anonymous says I agree about Inspira. I've had a number of issues. Anonymous says I agree that the HMO options have been great, would prefer not to have reduced options with the high cost of the PPO plan. Understood. And Anonymous says, would you consider looking to a plan that does pay for GLP-1s at a higher monthly cost for an employee? With a cost of $1,500 a month, an increase of the plan cost would still be better than paying the full amount. For a chronic disease, we should have a better option than what is currently on the table. So that was one of the things that was suggested by the Senate Council. And the example they used was IVF, where it exists in one plan and not the other. And would there be something we could do like that? On this timeline, we haven't been able to sort through that, but I understand why that would be a desirable option to somehow. I'll say this, though. It's not like the insurance companies don't understand the costs, right? So uh, having a special plan where it's available would be very expensive. Um, Anonymous asks, thank you in your role as president for working to be aware, invested in the options RFU considers for dealing with the issue and to bring transparency to what options are being considered. Well, it seems like an important thing for us to talk about. Anonymous says, thank you for keeping us apprised of these proposed changes. I understand that many factors play into healthcare costs and the employer can't control everything. That said, it would seem an increase in the employee's share of premiums and/or deductible responsibility will reduce the overall value of the employee's total compensation package. Is that correct? Can you please expand a bit on some of the options you mentioned to potentially offset some of these increases in terms of other benefits? So, yeah, the more you pay, right, the more any of us pay, the less disposable income we have, right? If you're thinking about whatever that difference is. This is an increase. The 80/20 means that we are passing on some of that increased cost to the employees. There's no doubt about that. And can you expand a bit on the options you mentioned to potentially offset these increases in terms of other, but well, at least what I was thinking of was the $1,000 contribution to GLP-1s and the contribution to the health savings accounts as things that we would be doing to try to help with this. Obviously, that doesn't mean something to everybody, because if you're not on a GLP-1 and you're paying a higher premium, that $1,000 doesn't do anything for you. So, that's one of those, we recognize that GLP-1s are doing something important and we're trying to figure out a way to make that work for people. But that was what I meant really for offset for other benefits. Sally, was there something else I should have been thinking about?
No, I don't think so. I mean, healthcare is going up. I mean, everybody is looking at increased premiums, and we need to share that cost because the university is just not able to absorb that amount.
Anonymous asks, does the current deductible and out-of-pocket amount restart in October or December?
January 1, the out-of-pocket and deductibles reset.
Anonymous says, greatly appreciate the transparency and what's going on. I know globally across Blue Cross Blue Shield is in the 10 to 15% increase range for fully insured companies. Are we so much higher because our PPO is self-funded? We are higher because we have an older population and we are using healthcare. I think appropriately within that, but we have a group of people who um, are need medication and need care, and that means our utilization is higher than our peers. Does that sound fair, Sally?
Yeah, and I would say, when we look at the PPO plan and being self-funded, the actuaries kind of estimate how many people will be in that um, higher than that 145,000 pool, and we have far exceeded that over the last 12 months. So
So,
we, yeah,
yeah. I mean, the stop loss cost itself was the largest thing. We gave you the sort of total increase in cost. The stop loss cost on its own increased an even larger percentage. So, and that's because we're going over that 145 and the insurance company is charging us more. And insurance is just a actuarial business, right? Um, so Anonymous says, I get emails from Blue Cross Blue Shield Twin Health. These services are no cost to us, correct?
correct.
I'm just going to wait for a moment or two and see if there are any more questions. We are very close to the top of the hour. Um, and we have answered 34 questions.
Yay. And we are available for more. Please make an appointment with Melissa or I. We are happy to discuss this with you and provide additional information as we can. Um, this is a tough one.
Yep. Anonymous asks, I'm sorry, I missed 90% of this. Will it be available somewhere later? All the town halls get posted. So it usually by Monday. We have a little, so um, Maria says, thank you so much for all the information. You're absolutely welcome. So I'm going to take this pause as the top of the hour, and so I want to thank Sally Madden and Melissa. Let's see here. Anonymous says, I've never had an employer put the information out for an employee to be aware of what's being faced. To have the information ahead of time is wonderful. Thank you. You're welcome. So I want to thank Sally Madden, our Associate VP for Human Resources, and Melissa Haley, our Payroll and Benefits Manager, for joining me today on the Town Hall. Thank you guys so much for your expertise and all the work you've put in over the last month or so.
Thank you.
Thank you.
And over there in the questions is the Town Hall archive where you can find them all, including last week's most excellent town hall with Rosalind Franklin, or about Rosalind Franklin and her birthday. So I want to, anyway, thank our panel, and I want to thank you all for joining us today. Thank you for all you do to support our faculty, our staff, and our students. It is the work of people like you that make the university such a special place to be. It is Friday. I hope you get to have a weekend. Take care, everybody. Bye-bye.